Welcome to Medical Logistics 101 Back Pain Overview. This video is for educational purposes only. It is not medical advice, does not replace a medical evaluation, and may not apply to your situation. If you have symptoms or concerns, please speak with a licensed healthcare professional. My goal is to help patients enter healthcare with a map instead of a blindfold, and to explain how clinicians think through these problems in resource-limited settings. Definition. Back pain is discomfort arising from the spine, paraspinal muscles, nerves, or surrounding structures. Most cases are mechanical and benign, but a small subset represents infection, malignancy, vascular emergencies, or neurologic compromise. Signs and symptoms. Localized lumbar or thoracic pain, pain worsened by movement or position, muscle tightness or spasm, radicular symptoms, this would be like sciatica, shooting pain, numbness, tingling sensation in the lower extremities, weakness or numbness in a dermatomal pattern. This would be the sensory dermatome, the same type of sensory dermatomes that are affected by shingles. Night pain or constant pain, that would be very concerning for me. Systemic symptoms if it's concern for infection or malignant causes. Exam findings, general appearance, mobility, distress, ability to sit or stand. Oftentimes I'll enter the room and these people are just pacing around the room. They're not able to sit. They're certainly not able to lay down on the bed. Vitals, fever, tachycardia, hypotension. If I see severe back pain in someone with hypertension, that's a major red flag for me. Back exam, tenderness. Do they have a step-off deformity when you palpate their spine? Is there deformity in the area? Neuro exam, strength, sensation. You should check reflexes with these patients. Straight leg raise. Do that commonly to check for radiculopathy. Pulses in lower extremities, signs of DVT. I always document pulses in these patients. I want to check for that. Certainly also at the same time, I'm usually checking for calf tenderness or swelling. I want to make certain there's no sign of a deep venous thrombosis, a blood clot. Gait, is it antalgic? Do they have foot drop? Is there instability in their gait? And last, rectal tone, perineal sensation should be done if red flags are present. If you have numbness, certainly a complaint, the patient's complaining of pain around the perineal area or the rectal tone is absent, major red flag that you're getting something like Cauda-Equina syndrome. Diagnostic studies, most patients don't need imaging. Use imaging only when you get red flags or concerning features are present. Obviously, x-rays, certainly possibly a CT if there's concern for trauma or osteoporosis. MRI, if there's neurologic deficits, infection, malignancy, or as I said, Cauda-Equina syndrome. CT is what we typically use for trauma. MRI is not always available acutely, depending on your location. Labs, CBC, erythrocyte sedimentation rate, or C-reactive protein if there's concern for infection. I always get a UA in these patients if nothing else, to rule out renal mimics like pyelonephritis and kidney stones. UA is going to be obviously very helpful from the standpoint of looking for hematuria that you would expect to see with the kidney stones or infection signs that you would see with pyelo. But also it gives me an idea about their urinary function. Differential diagnosis mimics mechanical, sprain, strain, degenerative disc disease, radicular causes, herniated discs, spinal stenosis or sciatica, infectious causes, spinal epidural abscess. You sometimes see that with IV drug use and also in diabetics. Vertebral osteomyelitis would be something you would have to be worried about from an infection standpoint. Vascular causes, of course, the famous abdominal aortic aneurysm with dissection. You may see retroperitoneal bleed with that. That's one that you have to catch immediately on arrival. Traumatic compression fractures, burst fractures, which you often see. Renal mimics, pyelonephritis, kidney stones, other mimics. Pancreatitis can certainly cause pain in the back. I typically will see some epigastric pain with that as well. As I said, DVT certainly can mimic sciatica symptoms, pain in the leg. Again, you need to document an exam. Do I have calf tenderness? Do I have, especially if I have calf swelling? Shingles. Shingles doesn't always cause the rash in the early stages, and it can cause certainly pain in the lower back. And that dermatome pattern, I would expect that to be on one side. And obviously, we're going to see the rash typically at some point. Red flags for me, saddle paresthesia, bowel or bladder dysfunction, progressive motor weakness, fever with back pain. That's going to need further workup. History of IV drug use, you certainly have to be vigilant with these patients. Recent infection, immunosuppression are always high-risk patients. If patients having a lot of night pain with this, that's always kind of a red flag for me. Other red flags, unexplained weight loss. That makes you certainly think about malignancy. Trauma in the elderly. And you know, when I say trauma, it can be very minor trauma. Pulsatile abdominal mass, a major red flag, of course, for AAA. Pain just out of proportion to what you would expect to find. History of osteoporosis. As I said, this is a big one. Risk for compression fractures with minor or even no injury. I heard of a case once, a patient who had a acute compression fracture of her lumbar spine. She had a previous history of severe osteoporosis, and the only thing she did was coming to a sudden stop at an intersection when she was driving her car and pressing on the brake. So just very minor trauma, in some cases no trauma, and they can have spontaneous compression fractures of the lumbar spine, or any part of their spine for that matter. Assuming other pitfalls, assuming sciatica without doing a neuro exam, missing an epidural abscess in IV drug users or diabetics, missing pyelonephritis or kidney stones. I would always get that urinalysis just to make certain of that. Missing the abdominal aortic aneurysm masquerading as back pain. The beauty of these days, you can do a fast exam, the focused abdominal sonographic test, that ultrasound that's in the exam room, and this is not down the hallway in the radiology department, but you can do it quickly when the patient arrives if there is a concern for that. Not checking for urinary retention and suspected Cauda equina syndrome. These days, they can do a bladder scan in almost every ER, and you can quickly get an idea about urinary retention. Disposition. Usually home with follow-up. If for mechanical pain, mild radiculopathy without deficits, this would be like sciatica. No red flags such as saddle paresthesia or bowel or bladder habit changes. Obviously, fever would be a major red flag and need further workup. Able to ambulate, and they have stable vital signs. ED observation or admission. If there's severe pain limiting mobility, uncertain diagnosis, if they got to have IV pain meds to get their pain under control, concern for infection or malignancy, they may need to be observed in the ER or possibly admitted. Transfer, this particularly is relation to what setting you're in. If you're in a small rural hospital, you may have very limited resources. Suspected Cauda equina syndrome, progressive neurologic deficit, spinal epidural abscess, malignancy with cord compression, a vascular emergency, obviously, with the AAA. Any case needing MRI emergently, because that might not be available locally depending on where you are. In closing, if this is the kind of content you find helpful, please like and subscribe. If there are topics you'd like to see covered, you can email me at medicallogistics101@gmail.com. Remember the dangers and always what you know, but rather what you can't afford to miss. Thank you.